Assalamu alaikum. The long clinical consultation day. First scenario, Mr. John Smith. He's 52 years old man, presented with dysphagia. The vitals are normal, full blood count, liver function, electrolyte, urea, and creatinine are normal. He's currently on lansoprazole. Please take history, examine the patient, address his concerns. Ready, Dr. Salma?
Yes. Hello.
Yes.
Hello.
ready.
I am Dr. Ahmed. I'm doctor in the clinic today. Can I confirm your name and age, please?
I'm Mr. John Smith. I'm 52 years old.
Today we are here to discuss some issue related to your health condition, examine you and address your concern. Is it okay with you?
Okay, doctor.
During our conversation, we need to take some note, but be sure it will be confidential. Is it okay with you?
It's okay, doctor.
Can you tell me what bring you to the clinic today?
Thank you, doctor. Doctor, for the past 4 months, I've been having difficulty in swallowing, doctor.
Okay. Can you tell me more about it?
Thank you,
Only
doctor. Doctor, yeah, like I said, it started 4 months ago and it's getting worse, doctor. Don't know. Yeah.
Is it feel like food is stuck?
Yes, doctor. Yes, doctor.
Okay. This is for solid only.
Doctor, both solid and liquid, doctor.
Okay. Um, uh, can you point for me where is the location exactly in your
Doctor, I cannot really
tos-
point because sometimes it's up, sometimes it's down, but it's majorly here, so I can't really point exactly where it is, doctor. Yeah.
Is there any pain associated with
No,
okay. Is there any weakness or any tremor or
tremor. What do you mean by tremor, doctor? I don't understand, but there's no
sorry,
weakness.
I mean any shaking in your hand?
Shaking in my hands. No, doctor.
Yes. Okay. You feel you're weak?
Weak? No, not at all, doctor.
Okay. Is there any problem in your balance?
Balance? No, doctor. I'm
Yeah.
okay, doctor. Yeah.
Okay. Is there any drooling of saliva or
No,
food?
doctor. No, doctor.
Mm. Is there any nasal regurgitation?
No, doctor.
Any aspiration of food?
Aspiration of food? Not that I can remember, doctor.
Okay. Is there any heart pain
Heart pain? No, doctor.
or any chest pain?
Chest pain? No, doctor. No, doctor. But
Okay.
sometimes I do have chest pain, but I've been on like since I started taking lansoprazole, I've been better. The chest pain has not been there.
You took lansoprazole and you improved on lansoprazole?
Since the doctor I met in my
You feel
GP,
better?
yes, but not. I don't usually have the chest pain any longer.
Okay. You mean you didn't improve?
I had it one time, but since I started taking lansoprazole, I don't have it again, doctor.
Okay. Okay.
Mm.
Is there any weight loss?
I don't really think so. Well, I don't. Most likely about 1 to 2 kg, but not, yeah, that's 1 to 2 kg over the past 6 months.
Mhm. Is there
Mm.
any high body temperature?
No, doctor, no.
Lumps or bumps in your body?
Lumps and bumps, no, doctor.
Uh, Loss of appetite?
No, doctor.
Okay. Is there any skin changes?
Skin changes?
Uh,
Mm, not really, not really. I don't think I have any skin changes. It's just that sometimes my hand just feel as if it's becoming shiny, kind of.
okay.
Mm.
Okay. Is there any tummy pain?
No tummy pain, doctor. No
Tummy distension?
tummy distension. No, doctor.
Change in bowel habit?
Change in bowel habits? No, doctor.
Okay. Is there any change in your water work?
No, doctor.
Any heart racing?
No, doctor.
Uh, uh, any I already asked you about chest pain. You tell me no. Okay.
No, no chest pain. No,
Yes. Is there any fraud urine
no, doctor.
or change in the urine color?
No, doctor.
Can you tell me when you eat? You eat slowly or need time to clear your throat from?
Yeah, if I eat normally, but I thought that I feel as if the food is still there, doctor. Mm.
Okay.
As if the food is
Um,
stuck in my body that is not going down.
mhm, mhm, mhm.
Yes.
Is, is there any headache,
No, doctor.
any memory problem, or any vision problem?
No, doctor.
Okay. Um, uh, is there any past medical history should be aware of?
No, doctor. No.
This
And
is a first time.
yeah. It's just that I do have yeah, this is the first time I'm having this complaint. I first started by sometimes I do have pain sometimes. The doctor said I have, gave me lansoprazole, but I've been better since then. No problem.
Okay. This is before how many months or how many
No,
what
within
time?
this period, within this period,
Within
within
this
this
period.
period. Yes,
Before
yes,
nothing,
doctor.
no any past medical history of same condition.
No, no, I don't have any. I've not been admitted. I don't have any diabetes. I don't have any high blood pressure, doctor.
Oh, yeah. And even no past medical history of similar condition.
No, no, no. This is for the past 4 months. That's when it started. Before then, there's nothing like that, doctor.
Okay, 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 okay. Is there any drug allergy?
No, doctor.
Now use any medication?
No, doctor.
Any over-counter medication?
No, doctor.
Sorry for this question. Any recreational drug use?
No, doctor.
Okay. Um, can I ask you some social question? What do you do for a living?
Doctor, I'm a teacher, doctor.
Okay. Um, do you smoke?
Yes, I do. I smoke, doctor. I do.
Drink alcohol? Do you drink alcohol?
Yes, occasionally, just once in a while.
Okay.
Not
For
very.
smoking, I am advising you to stop smoking, and I can help you by referring you to smoking cessation clinic.
Okay,
And
okay,
for alcohol, also, I am advising you to moderate amount of alcohol intake.
okay, doctor.
Is there anything you want to tell me about your condition?
Yes, doctor. What do I have, doctor?
Um, uh, as you mentioned that you have from a history that you have difficulty in swallowing and like a food is stuck. Uh, we need to do some investigation to reach diagnosis.
Okay, doctor. That'll be nice. That'll be nice.
Any other concern or any other something you want to add it?
Doctor, like I said, I want to know what I have. Is it cancer?
Um, uh, Now we cannot say is it cancer. There is suspicion, but again, is that you have no weight loss, uh, no weight loss, and so it may be, but we need to do further investigation.
Okay, doctor. Thank you, doctor. Thank you.
Thank you.
Thank you.
Can you let me to examine you, please?
Yes, you can examine me, doctor. I've sent depending on what I've sent the picture to Dr. Baz, depending on what you want. What do you want to examine?
I want to examine hand.
The hand, okay.
Is
Dr.
there
Bazim,
any?
sir, can you please send the picture, sir? Hello, sir. I've sent it to Dr. Bazim, but let me see if the picture is still here.
Okay.
Okay. Yeah. That's the hand.
Yes, the two hands picture in the chat box.
You've seen them?
Yeah, I have sent them. You can see it. Dr.
No, I
Salim?
can see it. Yeah. I'm
Yeah.
asking if Dr.
Yes,
Sama,
These
can you
yes,
see it?
hands,
yes,
if you need
Okay,
yes,
that's
anything
it.
else, I will send.
Mhm.
yes,
You can resume your time.
yes.
What else do you want to examine?
Hand?
Okay, the hand is there. You can see the hand.
Any clubbing?
You can see the hand, just no clubbing. No.
Okay, okay. No clubbing. Mm, Um, sorry, I want to ask you one question. Is there any joint pain?
Joint pain. No, no, doctor. No joint pain, doctor.
No joint swelling?
No joint swelling, doctor. No.
Okay. Okay, I want to examine eye for any jaundice or pallor.
Okay, there's no jaundice and no pallor, doctor.
I want to see mouth for any oral
The
hygiene,
mouth. Okay, the mouth.
candidiasis,
The doctor, no, no,
Yeah,
there's
I
no
share them out.
candidiasis. You share the mouth for you.
mouth ulcer.
You can see it. I don't know. You can see. Yeah, I don't know.
Okay, okay,
You can see it.
okay, okay. I want to examine um, lymph node.
Okay, there's no lymph nodes, ma.
Is there any thyroid enlargement?
Thyroid enlargement. Okay, no thyroid enlargement.
Okay. Abdominal examination. Is there any organomegaly?
Abdominal exam. You use 2 minutes to do abdominal examination. There's no organomegaly. So 2 minutes for abdominal examination. If no organomegaly.
Okay. No scar. No scar. No organomegaly. Normal abdominal examination.
There's no scar in the abdomen. There's no organomegaly in the abdomen. What else are you looking for in the abdomen? Nothing.
Okay. Okay. Chest for air entering.
Chest. Entry is normal.
First and second heart sound.
First and second heart sounds are normal.
Any murmur?
No murmur.
Okay.
So
Any?
okay. You take
Tell me.
1 minute in doing that, checking for murmurs. 1 minute is gone already. What else are you
Okay.
looking for? I think
No lower limb edema.
lower limb edema. No lower limb edema.
Okay. Sorry, is there any ulcer in the genital area?
Genital areas. No ulcer. Is it exam? Okay, no ulcer. No ulcer.
Okay. Okay, thank you. Thank you for letting me to examine you.
Okay. All right. So can you are you done? Can you present your
Yes, yes, yes.
okay?
Thank you.
Can you present your
No, the concern first. 2 minutes for the concern.
concern? Okay, I think he has asked me. Okay,
Yes.
your concern.
2 minutes
Okay,
left.
go ahead with the concern. What doctor? What do I have?
Um, from the history, dysphagia and examination, and we have really to proceed some test and tell you about the diagnosis.
Oh, okay. Okay, thank you, doctor.
Okay, welcome.
Doctor, is it cancer? What I have?
I am still suspected maybe cancer, but again, is that you have no weight loss, but we need to
Okay.
proceed some investigation to confirm the diagnosis.
Okay, doctor, will my children have similar complaint, similar condition? Sorry.
Your tell me what?
Will my children have similar condition?
Your children have similar condition?
Yeah, What I mean is can it be a heredity? Will my children suffer for the same condition?
Um, uh, from the history and examination, I suspected that maybe hereditary hemorrhagic telangiectasia. It is inherited condition, and maybe yes, maybe affected.
Okay, all right.
Maybe by 50% children will be affected.
Okay, okay, all right. Thank you, doctor.
Thank you.
Okay, examiner time. You can start now, Dr. Hilary.
Okay.
Questions?
Can you tell me the positive findings in your patient and the likely diagnosis and differential diagnosis?
Mr. Smith, John Smith, 52-year-old, present with dysphagia. On examination, there is all investigation, abdomen and chest is normal, other than telangiectasia in the mouth and face. That's what I noticed.
Okay, what's your diagnosis and differential diagnosis?
My diagnosis may be hereditary hemorrhagic telangiectasia. Maybe esophageal malignancy, but again, is that the patient has no weight loss.
Okay. So, okay, how will you investigate this patient?
Apart from general investigation, full blood count, renal function, liver function, and inflammatory marker, we need to do also a clotting profile and genetic testing and endoscopy.
Okay. How will you manage this patient?
Education, firstly non-pharmacological treatment, education and counseling about condition, stop smoking and stop alcohol, multidisciplinary team approach, gut doctor or gastroenterology doctor, and also hematology doctor and specialized nurse.
Are you done?
Yes.
Okay.
Specific treatment after confirming the diagnosis by endoscopy.
Okay, assuming you do endoscopy and the endoscopy is normal, what would you you do an endoscopy and it is normal? What will you do next? Or probably will it affect your plan?
We will look for other tests.
Like what?
Like coagulation profile.
Coagulation profile is normal.
Normal.
Mm.
Genetic testing.
Genetic testing is normal. No genetic study. No genetic is normal.
Okay.
Okay, assuming this patient
symptomatic
told you,
treatment. We'll treat symptomatic treatment. Yeah.
Now, this patient told you in the history that he has some. When he asked about the skin changes, he told you that the skin is looking shiner than before. Shining than before. Does anything come to your mind when you mentioned that?
I didn't notice that skin is shine.
Yes, when you ask about it, you see that the skin has been looking, shiner than before. Does anything come to your mind?
No.
Okay. Now, can you look at the hand very well? Just look at the hand again very well. Look at the hand in the picture very well.
There is destruction of the nail.
The one in the look at the thumb. The one they show the thumb. This is something like a something in the thumb that's looking like something like it's calcified in a way. The thumb.
Thumb.
Look at the first. That should be the first picture. If I'm not mistaken. Is it the second picture?
Oh yes. This ulcer,
Okay.
like ulcer.
Yeah, like okay, can call like you can see like ulcer, but it's a it's carcinosis you are seeing there.
Oh, really? Oh my God.
Mm. And you can see the fingers. You can see how it is. Look at the. You can see how the. You can see sometimes it is that beautiful. So basically, you know, you've done well. Do you want me to score? Do you want me to score you? I should just go ahead because looking at the, you did very well. To be candid, you asked your issue
Okay.
was kind
In
of
the term
serious.
of differential, can you repeat the differential diagnosis, Dr. Salma, please, again?
I mentioned that mm, um, um, uh, maybe cancer, but again, is that
Okay.
the patient
After
mentioned that
after the picture, he said about, he told you about the
after
picture. Yeah,
after
what you can
picture
say?
systemic sclerosis,
Yes. Okay.
scleroderma, uh,
Perfect.
Okay,
And
beautiful.
but
what's
I lose it at all. I didn't think
it's
it
okay.
shine skin or
What you call it as a syndrome?
systemic sclerosis,
Yeah. In particular, what syndrome in systemic sclerosis?
limited systemic or diffuse, both of them. Here, I think is
Okay.
limited.
Limited in the form
If
of what? What syndrome? Do you know a syndrome can explain this condition? What do you call it?
uh,
You have calcinosis, right?
rhinoid in hand, you mean?
No,
Mm.
calcinosis at the hand, GERD or dysphagia.
Yes, this is Chris syndrome.
Yes.
Yeah,
Okay.
it's Chris,
Reynolds.
but
Yeah.
Okay.
yeah,
Yeah, this is what I want you to say.
Oh
Okay.
my God.
Okay. Thank
Oh,
you.
but I lose the case
It's
totally.
okay. That's
I
okay.
go very far from the case.
No problem. And now we'll hear Dr. comment, Dr. Henry comment, then I will comment.
all right.
During this
Thank
time,
you.
please post your scenario, okay? Yeah, you can
Thank
start,
you very
Dr.
much, Dr. Sama. The history you did very well in the history, but just that you didn't ask more about the skin features. You did ask about Raynaud's phenomenon. If there's any cold
Mhm.
in the hands, it changes skin coloration when they're supposed to cold. When you get the skin rashes, it does it feel warm. Even the other history, you didn't go deep to rule out other motility problem in this case. You try to rule out some of the neurological cause of dysphagia, which was good, beautiful. Even the myopathy cause, you didn't try to rule out because typically when you say a case of dysphagia, definitely two things will come to your mind: is it oropharyngeal or esophageal dysphagia? And then you ask about where does it feel the food sticking. He said it is not that constant. Sometimes he felt it in the down. Sometimes he feel it up. Basically, then when there's no cough, there's no choking. Those are features of oropharyngeal. The issue of those absence of choking, absence of in like you asked about as if he aspirated. That's choking. Is that not? He doesn't have it. All these are symptoms of oropharyngeal. Issue of those things are not there. Those coughings are not there. Those issue of difficulty in swallowing from the mouth, which is not there. Then you go down. You also try to talk about the esophageal causes, which in this case can be either mechanical or motility disorder. You will have the mechanical, but not all that. You ask about foreign body, which is although that will present as acute. The patient has GERD, which also cause intrinsic which can you ask about reflux, you ask about those ones that can cause intrinsic mechanical cause. Also, malignancy in this case is also doesn't have any odynophagia. Malignancy without odynophagia tends to and weight loss is not in this patient, so that tends to rule out malignancy. In as much that you also have a mystery of cigarette smoking, he didn't ask of he didn't quantify the pack years of the cigarette smoking. The patient said he smoke. Patient could be smoking one cigarette, one stick per day. You just start advice. You just start, advice. You should have asked, what is the pack here of the cigarette smoking? He did not ask. Same with the alcohol. The patient said, okay, he drinks occasionally.
Mm,
You just advise. It could be, patient
mm,
could drink it maybe once in blue moon, probably once every month or once every 2 months. You should have ask the duration of the quantity of the cigarette and the alcohol consumption. Very important in this case, but it not ask in this case. Then also you rule out also Chagas. You asked about fever, which was good. Patient does not have fever, no issue of body swelling. You rule out Chagas disease, which is also good, which can cause motility disorder too. Then the issue of achalasia, very, very important in this patient. Can cause because it can present with both solid and liquid dysphagia, which is a very, very strong differential in this case. Then also the issue of diabetes. The patient does not have it. That can cause that, maybe gastroparesis and co. Patient does not have that. That one is okay, basically. Then other things that you also should also rule out, which is foreign, like comprehensive, like extrinsic cause of mechanical obstruction, mechanical dysphagia, things like aortic aneurysm. You ask if he has any problem with heart problem. There's no heart problem. That tends to rule those ones out too. Other, if there's any mass, you ask of lumps and bumps. You have of which doesn't have. You also rule down to, which is also a good one. Then also in the examination, you just vividly, when you see a skin, you didn't examine the skin very well. You didn't examine the lungs. This patient also have in the lungs. You are supposed to check a full respiratory examination in this patient, because this patient has bibasal crepitation, but you only check about the air entry. That you only ask of the air entry, and I said that the air entry is normal. Air entry, that's what you ask. I was expecting you to say, okay, what are the auscultation findings, or what are if there's any crepitation. Typically, the patient might also in the cardiovascular system, you only ask about the murmurs. You didn't check if there's LAP2 for pulmonary hypertension. Although if you might see it also in CREST. You didn't ask for those parts, although because as when you have that diagnosis in mind before the examination, you should have. I know that you would have checked for them, but because of the fact that you did not entertain CREST, which is limited sclerosis, that tends to limit your examination findings. By and large, it was a good one, but I think these are just my own contribution in this case. Then, if prevention now, let's say in this case now, it is scleroderma, you entertain scleroderma, how will you investigate? Will you affect your investigation findings?
Anti-Smith antibody.
Anti-Smith, why anti-Smith? Why anti-Smith antibody? Why?
For investigation for systemic sclerosis.
This one for
SLE 70 for diffuse. Huh?
No, anti-Smith is not for that. Anti-Smith is for SLE. Anti-Smith is not for diffuse. Anti-Smith is for SLE. In this case, you want to do anti-centromere.
Centromere.
Anti-centromere, basically. For the limiting part. Why for the diffuse one? That is an anti-scleroderma 70. It gives you that, basically. So these are things you want to do other investigation too. This particular patient that when you listen and you get the crackus by basal, you may want to do your HROCT to rule out what pulmonary interstitial lung disease, which might present as pulmonary fibrosis in this patient. Also, if typically you probably see anything, you see any LAP2, probably you want to do echo to rule out what do you call it, pulmonary hypertension in this patient, or maybe you want to do right heart acceleration if there's means. Then also in this particular patient too, manometry is one of the gold standard, because when you do first of all, you want to do your endoscopy, like you do your endoscopy, which may be normal in this case, or probably might see maybe some gastritis features, or in endoscopy. But when you do your barium swallow gives you a clue, because it tells that probably it might give you a pattern in barium swallow that is keeping with a dysmotility pattern. Typically, you will see something like a dilatation of the esophagus. You see an absence of peristalsis or decreased peristalsis. I see what they call a patulous lower esophageal sphincter to be enlarged, unlike in achalasia, when you see a bed big appearance. And there's usually a rapid emptying in what? In crest, the esophageal dysmotility seen in crest. There's rapid emptying, unlike in achalasia, in which you see what? A poor emptying. You see bed big appearance, also absent peristalsis. Then also, manometry gives you more clearer picture. Manometry tends to differentiate both the achalasia and also the other differential diagnosis in this case is what? Is diffuse esophageal spasm. However, in diffuse esophageal spasm, what you see is what? Is an intermittent dysphagia, not progressive one like you see in this case, or continuous one. You see an intermittent, and definitely when you do your manometry tends to give you see a normal lower esophageal sphincter, realization time, and also you see the peristalsis which also be normal, as if there's no spasm in between spasm. So what differentiates between the achalasia and the dysmotility that is seen in crest is manometry, and then the positive findings of your anti-centromere antibody, and then your physical finding features like you see in this case, carcinosis, Raynaud phenomenon, in which you may want to do what they call capillary fold, nail fold testing to differentiate is it a primary Raynaud or secondary Raynaud. Then also, in this case, like I said, when you do your manometry gives you a clue. In manometry, you see that there'll be the pressure will be decreased, which unlike in the achalasia, when the pressure is increased. However, the peristalsis is absent. There's absent peristalsis. The same with achalasia. There's also absent peristalsis in achalasia. So typically, that tends to differentiate achalasia and the esophageal motility that is seen in what? Dysmotility that is seen in crest. Then also, as part of the management in this case too, management is a multidisciplinary approach, like you said, which will involve, in this case, you want to involve the gastroenterologist, the rheumatologist, the pulmonologist, because of you also want to involve dietitian too. Who play a good role in this case too. Dietitian too is very, very important in this case. After dietitian too, you want to also involve, if possible, because if there's a need for surgery too, other what do you call it again? What do you call it? If there's need for surgery too, like in this case, there may not be needing surgery in at this time, but if there may be need, but the main specialty you want to involve in this case is one, the respiratory physician, the physiotherapy, renal physician, which is what do you call it, nephrologist. If there's then also cardiology may be also involved for a long time. And then
swallowing
salt team, beautiful. Thank you, Dr. Bazin. Thank you, sir. Your sorting, very, very key in this patient. These are the other things you want to say. Then, and part of management, you may want to commence steroid for them in short acting for short time. Then later, you may test for immunosuppressants such as mycophenolate, and methotrexate. But in this case, you have to be careful for methotrexate because of the fact that they already have some pulmonary fibrosis. So you may choose to just go with mycophenolate, mofetil. And if it doesn't respond, then it can escalate to cyclophosphamide. Therefore, the renal phenomenon, we want to start with nifedipine. If that doesn't respond, you want to proceed to prostacyclin, and the rest of them. Then for the carcinosis, we want to do some laser therapy. The laser therapy, which can be used. So these are the way you just say it. But by and large, that is my own contribution. Thank you, Dr. Bazin. Thank you, Dr. Sama.
Okay, thank you, Dr. Henry. Your scenario about Mrs. Samia, 28 years old, complaining of jaundice and tummy pain for 5 days. I will comment, then we can start the practice. So my comment for Dr. Salma. Before I comment, the picture, you share us telangiectasia at the face.
Yes.
Right, Dr. Henry?
Yes.
What the relation?
Yes, that's crest. The T in crest is telangiectasia. The T in crest is telangiectasia.
What I know, telangiectasia in the hand, not in the face.
No, it can be found it can affect the hand, the mouth, or the hands. It can affect the mouth, the face, The dysphagia in crest can affect the face, the mouth, and the hands. These are the three places of manifestation.
Okay.
Yeah.
Oh,
Mm.
okay. Thank you, Dr. Yan. So back to the comment, as the clinical communication skill, you took good history, but when you start to ask about systemic review, you didn't ask full details questions. The joint pain, the skin tightness, the rash, difficulty of combing, or any myopathy or muscle pain, all of them are important to ask. You have to put good differential before entering the station, Dr. Salma. Not only to take history. You have to put in your mind some differential I want to roll out. What are the most common cause of dysphagia in paces? Myasthenia, right?
Mhm.
And
Mhm.
our case today, systemic sclerosis, usually coming. And you can add to them, as you said, the oropharyngeal, like bulbar weakness, I mean weakness. So you can say dermatomyositis or Parkinson. But in such age, you have to think about the causes in younger patient. Dermatomyositis also can cause this weakness. You try to localize the area of difficult swallowing, and you conclude that it's at the area of the chest. So you are talking about esophageal, right? So you have to rule out what can be the cause in the esophageal, the level of esophageal. Achalasia, one of them, esophageal cancer, one of them, esophageal dysmotility, one of them, and this is the most common cause in paces. The esophageal dysmotility in the form of scleroderma or systemic sclerosis. Okay, so you have to ask about skin tightness by name, not only skin change or any skin rash. You can ask any skin change, but if he denied, you can ask about any tightness of the skin. Don't forget
Mhm.
this one is very important. The point of
Mhm.
decreased weight, whenever you have even 1 or 2 kilograms, you have to know is it intended or no. Okay, even it could be something important to address. You just ignore it like it's 1 or 2, which is not
Is
important.
mentioned that 1 or 2 kg lost?
He mentioned, yes, I have lost 1 to 2
Uh,
or kilograms, but he didn't ask about appetite. How this
mm,
appetite of the appetite of the patient? Don't minimize the question of the package of constitutional. Don't say 1 or 2 question only. Sometimes the all question might have one answer will be conclusive, but if you ask one question only, you might miss the part of constitutional symptoms. So ask all the question together. Okay, you
okay.
finish.
Okay.
The time was good enough to ask all the history, and I think you have extra time also to examine.
Mhm.
So the clinical communication, you miss some of the question which can help you to reach diagnosis. So please take care next time. For the differential, of course, because you didn't correlate the picture, you couldn't put the most important differential. You said telangiectasia. I tried also to correlate the telangiectasia to the difficult swallowing, but it's not that much important. Or you can link the telangiectasia as a hereditary telangiectasia related to the dysphagia. I cannot say it could be the reason. Okay. Actually, I thought about Plummer-Vinson syndrome, esophageal web, from the picture, but also it cannot be explaining the skin shining and other finding in the patient. Cancer, always put it in your differential whenever you have loss of weight, okay, and you have difficult swallowing in such age, plus the patient is having history of smoking and alcohol. So whenever he said, I have do I have a cancer, put it in your list, even in the bottom of your list, but still one of the possibility will be cancer. Okay.
Mhm. Okay.
Yeah, the question for any pain is very good question. Any pain while swallowing, to rule out adenophagia, this one can rule out esophagitis, drug-induced, or candidiasis, which can cause also pain at the esophagus during swallowing, which is also a good question. But try to ask more about the GI symptoms. Any feeling sick, any throwing up, any tummy pain, tummy discomfort, change of the bowel habit, all of them as a relevant system. You try to follow the approach, but when you start to ask the systemic review question, I think you minimize the systems. You didn't ask all systems. The CNS, I think you asked earlier about CNS question, weakness or numbness, right? But you didn't ask
Mm.
about headache and vision issue, dryness in the eyes. Sometimes, yes, no need to ask in details, but at least to find out what could be the reason of this presentation. In
Mhm.
such female or male, usually female, they are commonly having autoimmune or connective tissue disease. So try to analyze more regarding these diseases. Past medical history, ask good. Any surgery, any admission in hospital, any allergy. Okay. Again, it's musculoskeletal part, the shining of the skin, the calcinosis you didn't notice in the hand, the ulcer, and the tightness of the skin, as I said. Even Raynaud, you can ask about change of the color from red to white, then blue. Okay, you have to ask these questions whenever you suspect scleroderma. The examination, of course, you will miss the mark because you didn't examine the hand well. You didn't notice, I mean, but you examine the hand. Of course, we have to examine the hand, but you have to know what's there. So identify the finding. You didn't pick up any finding in the hand. The swallowing, you try also to examine for the thyroid, which is good, as a goiter, to rule out either by question or examination. You have to. Okay, goiter, one of the also important causes to rule out compression from outside. Okay. Then the differential, again, as I said, you didn't get the case. The welfare, the concern. Yeah, the concern, you answer all of them. However, he asked you about the children or any inheritance. What do you think now, after you know the case now? What do you think the inheritance of scleroderma? Is there any possibility to be inherited?
I think yes, there is running in the family.
As as a genetic,
Hmm?
as a genetic or something else? Yeah, all
As what?
autoimmune condition runs in family, but not
Okay.
as a genetic one.
Not as the genetic. Yes, yes.
Yeah, so you can tell him your kids might have possibility to have any of these condition compared to other normal population. Okay, all
Mm-hmm.
autoimmune, as you know, some families they are having a lot of autoimmune diabetes, thyroid, but not as a genetic one. Apart from autoimmune polyglandular, the autoimmune itself runs in family in this way. So they are having this possibility, but not as a genetic one. Okay.
Okay.
Okay. You have any question or comments?
Yeah, I guess I will add something.
Dr.
Dr.
Mukhtar,
Yeah, Dr. Salma, she
Curtis.
start what I like. She's fluent and confident, but she feel in the communication and history little bit hesitant regarding. Yani she feel like she lost.
Yes.
She miss. Yeah, she lost, and then she did not find a point to come to the right way. She miss a lot in history, for example, the notes. And if you become systematic, you will be better. For example, even in systemic review, because you did not ask about the respiratory symptoms. You did not ask from the start. I will not ask about the renotes, but after you see the pictures, yeah, you're supposed to think about that. But again, I will say, like Dr. Basim said, if you will not do something in 5 minutes before the station, what is going, what I will expect in this patient came with difficulty in swallowing, you will face little bit difficult. So regarding the examination, also you did not. And because you did not reach any diagnosis in the history, also in the examination, you feel you are like you don't
Yes.
know what from which point you will start. Although yeah, the doctor shared or sent the pictures, and there is obvious. He said there is shiny, and there is skin tightness in the pictures, and there is calcinosis. Although you got the telangiectasis, when you got the telangiectasis, I said maybe you will get the crest. And in the history, you missed to ask about the renotes. So that this is clinical finding. If you miss the clinical findings, this will affect the differential diagnosis, the clinical judgment, the concern. So everything's again regarding the criteria for evaluation, it will be affected.
That's
But I
good.
think next time, I think if you face this case, you will master it, and this is a good thing for you, by the way. Thank you.
Perfect. Thank you, Dr. Mahmoud. It's nice comment here. They are calling it as linked skill. Linked skills means that if you will not know the case, you will not do the physical examination, you will not do the identify the finding, you cannot give good differential, and the concern even you cannot answer them properly. They might affect the whole skills marks. Maybe you can take at least 16 if you talk, if the examiner give you 2 marks borderline in each skill, you might get 16 out of 28 if they are kind. Some of them very tough, they can give you even unsatisfactory, so they might be less than 16. Okay, so take care of this. You have to put good differential before entering the station. I have young with dysphagia different than dysphagia in elderly. Elderly, I will think about neurological weakness, stroke, TIA, or Parkinson plus. Okay, but I cannot say Parkinson in 40s. Yes, it's could be happen, but it's not common. So I will think about the other, the dysmotility disorder, esophageal dysmotility, okay, or something related to the achalasia or cancer, or as I said, the goiter, myasthenia gravis. So put differential that makes sense regarding the age and the gender. Okay, female always common with autoimmune, but the male are common with another disease in this way. Okay, drug history, you have to know all details. Medication he's taking, it might be one of them. And if you have a lot of medication, you can say this is drug induced, whatever. Drug induced esophagitis, drug induced, according to the case, I mean the complaint. So you can put as a differential drug induced if it can fit the differential, okay? I think, yeah, we are done with the comment. You want to add anything, Dr. Salma, before moving to the next scenario?
Thank you.
Okay. Now, Dr. Nari, turn. Ready?
Yes, I'm ready.
Okay, here you go.
Hello, hello.
Hello? Hello?
I'm Dr. Henry. May I confirm if you are Miss Sama, 28 years old?
Yes.
Okay, I'll be seeing you today, and in case during the course of the conversation with you, if you have any condition, please feel free to let me know. Can I please go ahead?
I have yellowish discoloration in my eyes for 5 days.
Okay,
And also I have tummy pain associated
okay,
with this jaundice.
okay. Can you tell me more about this your the yellowish coloration of the eyes and the tummy pain?
I don't know, doctor, but it's coming together.
Okay. Is the eye changes? Is it getting worse?
Um, Same
Same.
within
Okay.
the
Okay.
yes, yes, yes.
Okay. And do you know of anything that's do you know of anything that might be the cause of the change of eye color?
What?
Okay. Do you know what might have caused the change of eye color you are having?
I don't know what is the causes. Only just I notice like this.
Okay. What of the tummy pain? Can you tell me, was it sudden or it has been, it's gradual in onset?
Uh, is a moderate pain, uh, and sometime increase, sometime coming going.
Okay. So sorry about that. Do you know of anything that you do that make it goes away and anything that you do that make it increase?
I didn't notice, doctor.
Oh, okay. Any swelling on your tummy?
Uh, Yes, doctor. Little bit. I feel like some distension in my tummy.
Okay, for how long now?
Um, I'm not sure, but I noticed within these days.
Oh, okay, all right. Any loose stool or constipation?
No,
Okay, any do you feel sick or you throw up?
what?
Any feeling sick? Do you have any, vomiting or
No, no, no,
yeah?
no,
Oh,
no.
okay, all right. Do you, any fever?
Uh, no,
Any weight loss?
no.
Okay, do you have any condition before that you have been managing?
Uh, this is first time to happen to me.
Okay, have you been diagnosed of any condition, any liver condition, or any heart condition, or any high blood pressure or diabetes?
No, 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 no blood pressure, no diabetes.
Oh, okay, okay. Do you have any surgery? Have you had any surgery before? Surgery?
Uh, uh,
Uh,
surgery?
any surgery?
No,
Surgery? Have you had
only
any surgery?
no, no,
Oh,
only I have abortion 2 times before.
oh, so sorry about that. The abortion you had for how old was the pregnancy when you had before before you had the pregnancy loss? How many
Yes, I
weeks?
mean pregnant. Yes, I
How
mean
many
I
weeks? How
mean
many
pregnant.
weeks? Yeah, how many weeks? How many weeks? Sorry,
This
how
is
many weeks?
happened 2 times.
Two
This
times. How
happened
many
two
weeks?
times.
Okay.
Yes,
Oh,
last time
okay.
three, 4 months ago.
Oh, okay. 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 Then outside that, you don't have any condition. You are taking any medication or any drug allergy.
No, 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 no any medication. Only I
Okay.
am taking. I'm taking only pills for
Pills,
contraception. Yes.
contraception. Oh, okay. All right. All right. If I may ask, sorry, do you have any? Do you take alcohol?
No.
Oh, okay. And do you smoke cigarettes?
No.
Do you have any? Do you take any recreational drug or medication?
Um,
Any party drug?
no, no, no. Only as I
Okay,
mentioned to you, only I'm talking pills.
okay, okay, okay. Any family condition of similar condition, similar problem? Any family history?
Um, I didn't notice anyone like has the same
Okay,
condition.
okay. Any blood transfusion?
Yes, before when I admitted for operation done for my losing my pregnancy, is
Okay,
given blood transfusion.
okay, okay. If I may ask, sorry, do you mind? I want to ask you some specific question, if you don't mind. Do you have any? Do you have any headache?
A little
A little
sometimes.
headache? Okay. Are you on any medication for the headache?
Only paracetamol as needed.
Or some? Okay. For how long have you been having this headache now?
No, no, no. Okay.
Okay, okay, now, okay. Do you have any confusion or any confusion or feeling confused at any time?
No,
Okay, any eye problem with your vision?
no.
Okay, any seizure?
No.
Okay, no seizure. Okay, any problem with your swallowing?
Mild,
Swallowing.
mild, mild in my leg. Mild swelling in my leg.
So, okay, might swell in your leg. You have swelling in your leg. Okay, for how long now?
Mm. What?
For how long? The swelling is for how long? The leg swelling
With
is
the,
for how
all
long?
my condition is start suddenly. This is always within 5 days.
Okay, okay.
No,
You know,
no, no.
okay. Uh, any reason of your heart? Any
Um,
heart
little,
raising?
little
Little heart
raising.
raising.
Yes, sometimes. Yes, sometimes I feel raising in my heart.
Oh, okay. And then any chest pain?
No chest pain.
Any difficulty in breathing?
No,
Any cough?
no,
Any lumps and bumps?
no. No.
Any skin rashes?
No.
Okay. Any weakness of the body?
Little I am tired because of at that time when I am losing my blood in operation, but now is better, getting
Okay.
better.
Any problem with your water work? Do you feel maybe any dark urine
Hmm?
or any dark urine? Dark urine.
No, 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 no,
Okay. Any problem with your water work? Any reduction in your water work?
no, no, no change.
Okay. So and then if I want to ask, sorry, any recent travel? Do you
Uh,
travel recently?
yes, I travel, but I don't know is this related to this condition or no?
Yeah, it might be related. So where did you travel to, and what are the things? What was your mission, if you don't mind?
Mm, I travel. You mean where I go?
Yes, yes, yes. Where did you travel to?
I a small trip. I go to Egypt.
Egypt. Oh, okay. So
Yes.
what may I know? Sorry, this is not personal. Do you at the time probably have any? When was that? When did you travel? When?
When?
Yeah, when?
Before this illness, 2 weeks
Oh,
like.
okay, okay. Did you have any, sexual intercourse within the?
No,
Okay. Did you eat any foreign, any, look at the local dish in Egypt?
no.
Okay. And did you have any much? Okay. Then if I'm asked, sorry, are you married?
Yes.
Okay. Do you have any children?
Um. Only one because I am recurrently losing my baby.
Okay. Okay. So it's so sorry about that. So when you traveled, do you notice any leg swelling when you came back or shortness of breath?
When I came back. Okay.
Okay. Okay. If I may ask also, have you had any problem with what kind of job do you do? Sorry.
Hmm?
What kind of job do you do? Your occupation? Occupation?
My job?
Your job? Yeah, your job. Your job. Your job.
Okay. Okay. I am a teacher.
Okay. And how has it been affecting your job, your condition? How is it affecting your job?
Yes, doctor.
Okay. Then all right. The Do you mind if I examine you?
Yes. Okay.
Okay. So I want to look at your hand, please. Check for your hand. Check for the if there's dehydration. Look at the pulse. Check for the pulse. Check for any evidence of cyanosis, peripheral cyanosis. Look at the BP. BP is the normal. The blood pressure. Look at the eyes. Check for the eyes. Look at the Look at the jaundice. See the jaundice very well. Look at the mouth. Any pallor in the jaundice and in the eyes. Any pallor.
No. Mild.
Okay. Look at
Mild, Bala. Yes.
mild pallor.
No. Yes.
Okay.
Jaundice already there is jaundice.
Yeah, yeah. Then look at the mouth. Check for anything in the mouth. Anything in
Normal.
the mouth. Any
Normal. Nothing.
Okay, okay. Do you have any hair loss or mouth sores before?
No.
Okay. And then if I may ask also, then look at the neck, check for lymph nodes. Any lymph nodes, cervical lymph nodes. Then
No.
go to the abdomen, check for the abdomen, any organomegaly, any liver. The liver is enlarged. Is it
Yes,
shrinking?
liver is mildly large liver and mild tenderness also. There is tenderness in the right upper
There's
quadrant.
okay. Any spleen?
No.
Any ascites?
Yes.
There's ascites. Okay. And okay, then look at the check for the ascites fluid tree. Then look at the any changes in the skin, any scarification, any caput medusa, any distended abdominal veins.
No. No capitalization. It was only there is abdominal distension.
Okay, then check for the just look at the lecture for the epididyma, compound epididyma. Then also look at the back, any scar. Okay, you have not done any surgery before. Okay.
Yes.
Looking at that. Okay. All right. If I may ask, sorry, you. Okay. Okay. Do you have any concern?
Yes, doctor, what I have?
Okay, that's a good question. Looking at your condition that you said, I think you have a problem with your liver, basically, and that may warrant what you are presenting with now with your fever, and then with the with your height changes and your tummy pain you're having, and I just touch your liver and notice that it's kind of sore in a way. So I think you're having what they call acute hepatitis, and
2 minutes left.
that may be due to your maybe either the trip you went to, maybe you have had. I'm thinking more of it could be a hepatitis. If I'm asked, so before I go ahead. When was your last period? Your last menstrual period? When was it?
What? What's that? Last period?
Your last menstrual period.
You mean before how many يعني days?
When was your last menstrual period? When did you see your period last?
Um, uh, 2 months ago.
2 months ago. Okay. Are you currently pregnant? If I'm asked, sorry.
I'm not sure. I didn't do
You're
any
not sure.
test.
Okay. Okay. So most likely you may be having a liver problem, which may be either due to hepatitis A, hepatitis E, or better still may be due to your problem with your gallstone. We need to evaluate you on that. Any other complaint? Any other concern? Sorry.
Uh, okay. No, thank you.
Okay. Then and also I want to do a test for you. We'll do a pregnancy test to see if you are pregnant. Some antibody test to also rule out a condition called antiphospholipid syndrome. At the same time, we need to do hepatitis profile for you, hepatitis B and C, BC, and then basically then we may need to give you some fluid and go ahead and keep you on bed rest. How about that?
Okay.
Now, okay, and then I'll involve the liver doctor to come and see you, and then we'll look at other medical team too, alongside to make specialized nurse. We all come together, and then we'll review your case after the results. But I think so for now you have to go and do some investigation for me. After that, we can discuss that. Is that okay?
Okay.
Okay.
Time is up. The examiner question,
All right.
please. Dr. Salma, please.
Please present your case.
All right. I've seen this 28 years old woman who presents on account of jaundice and abdominal pain for 5 days duration. There's associated history of body leg swelling and recent travel to Egypt with however no history of fever, no weight loss, and no issue of cigarette smoking. On examination findings, is not in any of those distress. There's jaundice. There's with she's mildly pale, and there's evidence of hepatomegaly with mild ascites, as evidenced by shifting donors, and there's pededema. However, other other examination findings are unremarkable. And he has two previous pregnancy loss. Looking at the previous and recent blood transfusion, and also blood transfusion. So looking at my patient holistically, most likely my patient tends to have acute hepatitis, likely due to hepatitis B, hepatitis E, and hepatitis B and hepatitis E, basically. And also other differential diagnosis could be due to um, also be due to what do you call it? Active phospholipid syndrome manifested as what do you call it again? Budd-Chiari syndrome, and also looking at it could also be due to gallstone. However, there's no evidence of palpation. There's no. I couldn't feel any no fever.
Body care syndrome. So this is the top differential because the
Pardon?
patient has a recurrent. This is the top
Pardon?
differential of you. Top differential, first differential.
Yes, I said because the patient have we are thinking of antiphosphosis syndrome superimposed complicated by because of the
Yes.
hepatic venous thrombosis,
Yes.
which is hepatic venous thrombosis as part of my differential diagnosis.
Yes.
Then
Yes. Okay.
these are my differential
Yes.
diagnoses I'm thinking in this case.
Okay. What investigation you want to do for this patient?
I want to start by doing bedside observation by vital signs, then do urine deep, and then go ahead and do full blood count and differential diagnosis, liver function test. I want to do abdominal ultrasound scan and abdominal Doppler ultrasound to rule out portal and hepatic venous thrombosis, and also want to do antiphospholipid antibodies such as anti-lupus anticoagulants, anti-beta-2 glycoprotein, and cardolipin. I also want to do do other hepatitis B, hepatitis A, hepatitis B and C, then body profile, then do alpha fetoprotein 2, then also do I think these are the baseline investigation I want to do for now, basically. Then these are my investigation I want to do for now. Then INRO and protein time, bilirubin, and then for the ascites, if there's significant ascites because of the pain, I want to drain the ascites and then do check for the SAG, the serum acetic albumin gradient, and then from there proceed to do the serum. Then if the calculate the SAG, if it's greater than 1.1, I'll think of portal hypertension. If it's less than that, I'll have to think of other causes of non-portal hypertension in this patient. Thank you.
Okay, how to manage?
The management of this patient will include the multidisciplinary approach, which will involve the rheumatologist, the gastroenterologist, specialized nurse, occupational social basically the hematologist, and also patient will be counsel of disease condition, and also the pregnancy test. If pregnancy test is positive too, if pregnancy test is positive, we want to involve the obstetrician and gynecologist to also be involved in this patient, and then they will proceed to do to if there's need for article, if there's if the INRO is, we'll do the INRO and we following the protein time, and maybe I want to start my patient if there's evidence of start my patient on anticoagulant. If the urinary Doppler, if the abdominal Doppler is in keeping with thrombosis, we want to start anticoagulant. At the same time, we want to give if it's due to acute hepatitis, in this case, we want to start bed rest, give fluid rehydration, and then fluid rehydration, and then diet modification. Thank you.
Okay, what hepatitis could be as a differential?
Yeah.
What type
My
of
differential
hepatitis?
I'm thinking hepatitis E, hepatitis B, and hepatitis A. These are my 3 hepatitis I'm thinking because of the acute hepatitis in this case. And
So
also, it could too be due to the drug-induced liver injury. However, because of the OCP, he has been taken too. That's also differential diagnosis too.
perfect. Okay. But hepatitis A and E on the top. A and E, right?
A and E, and also A, E, and B.
A and E, not B.
Yeah, it can still be B because B can cause both acute and chronic. It can still be B too.
Okay, Dr. Sam, I can comment now. Dr. Salma, you are here. You can comment.
Yes. This is yes. I am sorry, I'm a little bit busy. But yes, this case body care syndrome in the background of recurrent miscarriage, and oral contraceptive pill, and sudden history, only 5 days acute history. That means clot is blocking the vein, portal vein. Hello?
Hepatic, not portal, hepatic vein.
Hepatic vein. Sorry.
Yeah.
Hepatic.
Okay. Continue.
Yes. Before this, you asked me any question, or what you mean?
No. I want you to comment on the all performance, the history, the examination.
Good for Dr. Henry is doing perfect.
Okay. What about the differential? So you put a differential hepatic carry, and the second is
Correction, pedicure, then we can think about also viral hepatitis.
acute viral hepatitis. Okay. Then
Yes.
the last.
Lastly, we can think about malignancy also, but again, is that no weight loss, no fever, no.
Yeah, and also acute presentation. You cannot say
Yes.
drug induced. Yes, you can say drug
Can be
induced.
drug induced or can be also autoimmune hepatitis.
Okay,
Can
but
be
again, it
hepatitis
will
as
be
well.
as a chronic course, not as acute one.
Yes.
Okay. Okay. Anything else you want to comment? Okay, so I can comment now. Thank you, Dr. Sama, for the case. Thank you, Dr.
Thank you.
Henry, for the practice. I think also the history was little bit disorganized. Yes, you analyzed the jaundice and the tummy pain, but the travel history here, you didn't analyze all of the questions. You won't roll out acute hepatitis. What do you think the question for acute hepatitis, either A or E?
Yes, if there's any foodborne,
Perfect.
ask,
Yes.
yeah. And I asked, I think I asked if there's any, if he kind of food he ate there, if there's any special. I also asked about vomiting and diarrhea, in which, he did not really
Yeah, but you want
give
to
me.
say this is related to the travel.
Yes.
Yeah, right. So you have to know also
Yeah,
when exactly she traveled, when
yeah,
she came back, anyone has the same symptoms, the
that's true.
vaccination,
Yeah, yeah.
and how the food was from outside or from the restaurant, local restaurant. Okay, you have to analyze these things if you want to say this is hepatitis A. Yes, it's not the case, but you can put it as a differential. And it's good
Mm,
differential, by the way. Jaundice with tummy
mm,
pain away from the ascites, which is not common with hepatitis A, but it can be. So one of your differential, and it will be the second differential, acute hepatitis A or E, as oral transmission, right? It's transmitted through the oral intake. So it will be with the food or infected meal. One more question. Anyone in the group have the same presentation? So you can say this is hepatitis A. Drug-induced OCP, as you mentioned, one of the differential. But the analysis of the miscarriage was good, but Dr. Selma didn't understand you. So try to ask at what age exactly you have this miscarriage. This is the question for Miss Antiphospholipid. Okay, when exactly it happened. So usually it happened in the first trimester, as you asked already. And you can conclude that it's high risk to be the case here. Along with the oral contraceptive pills, she was volunteered to tell you about it, but you have to ask all the question three P's: the pills, pregnancy, and the period. You ask later on about the period, and I think otherwise the job you ask, the impact, there is some lagging in the internet between you and Dr. Salma. It wastes some time for the examination question and the concern. But you cover all the points related to the skills, differential, you answer the concern well. The admission, do you think patient need admission? The decision of admission.
Yes, as it is. Yeah, the patient needs to be admitted.
Exactly,
Yes.
yes. Need to
Mm,
be admitted. Anticoagulant is the cornerstone of the management plan for this scenario, along with the multidisciplinary team as a pharmacological option and non-pharmacological option. The birth control pills should be replaced with another mechanical way or method for the contraception. The alcohol, if the patient is taking alcohol, supposed to stop alcohol because there is possibility of liver toxicity and cirrhosis in the future. The other things, yes, hepatitis, all hepatitis screening should be done. Not only that, A and E. Apart from that, you have to ask also about the other risk for getting the infection, like tattooing, piercing, blood transfusion. You are suspecting something affecting the liver, so you have to ask about all these bad risks or habits that can transfer the infection. Okay.
Yeah.
Otherwise, in the discussion, you did well. Even you mentioned the SAG, serum albumin acetic gradient, which is very important to know what cause you have, either portal hypertension or acetic cancer or infection, right?
Yes.
Yeah. Thank you, Dr. Renee. You have any question or comment?
Yeah, it was a good one. Thank you,
Mhm.
Dr. Salman. It was a good one.
Okay.
It was a
It
good one.
comes as antiphospholipid, it comes as paroxysmal nocturnal hemoglobinuria, it comes as factor Leiden, it comes as BIHST. Okay, any patient with high risk of thrombosis or hypercoagulable state, they might present with the Budd-Chiari syndrome. Even polycythemia rubra vera, they can present with. Okay, so be careful. It comes as acute onset tummy pain along with the jaundice and distension. Three of them. They are triad of jaundice, tummy pain, and ascites. Okay,
Yes, sir.
you have any question?
No, no, no. It was a good one. I
Yeah.
was initially I was go before we started. I have my differential diagnosis was gallstone. I thought of drug induced. I thought of hepatitis, acute hepatitis. I also thought of probably if he has maybe a background of hepatitis, maybe chronic hepatitis. Could it be maybe a malignancy because of the jaundice and the abdominal pain, malignancy transformation? I also thought of pancreatitis. I thought of what else again? These are my differential diagnosis I put forward
Don't
before I
don't for,
started.
yeah, the good thing here you put the
Mm,
possibility of chronic liver
mm.
disease. You ask for
Yes.
capnoidosa and
Mm.
spider nevi, but don't forget for the tremors. I'm not sure if you did the flapping.
I did not. I did not. I did not.
Yeah.
I did
Whenever you
not.
have
Yeah.
any hepatic
Mm.
patient, whenever you start examining the hand, do the flapping.
That's true. That's
Okay.
true. Mm.
Yeah. Plus the other finding like jaundice, pallor, checking the finger break marks for hyperglycemia if you suspect hemochromatosis. Family history is very important if you want to say it's Wilson or some inherited condition like hemochromatosis. So you have to rule out and to think about the other causes of chronic liver disease. However, it's not chronic one, it's acute onset one. So top of your differential will be Budd-Chiari syndrome. But you can put another differential as related to the family history or drug or something else if you find in the history related or can explain the finding. Okay.
Okay.
Thank you, Dr. Nari. We can open the discussion now. Anyone want to add any question or comment?
Yes, Dr. Basim, I think
Yeah,
Dr.
go ahead,
Harry,
Dr. Mahan.
Dr. Harry, he did great actually in the history. He did well overall. To me, he did great. Regarding the differential diagnosis, I think he put the Buchari maybe at the third option. Yani, the good things he mentioned it, but from the start when the patient asked him what is regarding the concern, he put the hepatitis. Hepatitis is good. This is one of the acute presentation. He put another thing, another differential, and the third one, he put the Buchari. The good thing, if you put the correct differential in your differential, this will be credit for you in the assessment. Also, you can also put, because this is acute, you can put the stones, because this is also already female. Maybe you can put the gallbladder stones or something like that. It's also something acute. Regarding the examination, Dr. Basim said also you can do full examination from the to exclude maybe sometimes it will become something acute or chronic liver disease. So you, if you mention or if you check the signs of the chronic liver disease, it will be also okay. Cholinicia, clubbing, nyconicia, flapping tremor, liver span. Maybe you can do like this. Also, in the clinical judgments, you did great, but I think you mentioned the coagulation at the end. At the end of the, it's better to mention it also earlier after you check the part of the general investigation. Mention immediately the coagulation and the good things. You admit the patient under the his specialty. Overall, you did well, Dr. Henry.
Thank you, sir.
Yeah, thank you, Dr. Mahjoub. Again, it's a good comment from you. I like whenever anyone want to comment with a positive or negative, even if he or she repeat the information. It's a matter of gaining confidence. And I like the way of Dr. Mahjoub commented. He's catching some of the mistakes which I miss, or he catch something positive which also I commented on or I miss. It's okay, but to put the spot on this thing, he add more comment and it will add more importance for this part of the comment. Let me add something to end the session. It's related to the second case. So whenever you want to investigate, as Dr. Mahjoub mentioned, start by the general investigation, CBC, coagulation profile, liver function, kidney function. And here in the second, as a specific, you have to specify some investigation related to your differential. So I suspected it's antiphospholipid. I should do the all screening for antiphospholipid antibodies, anti-cardiolipin, anti-beta 2 glycoprotein, and the antiphospholipids antibody. The other antibodies I should include here, the all autoimmune profile. I should do all of them, anti-nuclear antibody, anti-double strain, because usually antiphospholipid either comes as primary or secondary to autoimmune. This is the specific one. The bedside, blood sugar, vitals, oximetry, echo, ECG, urine dipstick, and the image or scan here will be ultrasound or CT, hepatic triphasic for the hepatic vein thrombosis. The invasive test, I will do acetic tapping for analysis. If you do so in this way, you get full mark in the clinical judgments. Okay. For the gallstone, if you want to add it as a cause of acute abdomen with jaundice, yes, I agree to put, but it will not cause ascites unless it's
Mm.
chronic one. Okay. So you can say, but against that, I will not find the ascites. Okay. Thank you, Dr. Henry and Dr.
Yes, I will
Henry.
add, Dr. Basim, for regarding
Yeah,
the
sure.
investigations. Some of them, they will say also the good notes. They said that you remind me.
Yeah.
Yani, you can divide the investigation to first general. Everyone he will say this is general. Then investigation to confirm your diagnosis. Confirm. Then investigation to find the underlying cause. Then investigation to see the complication. So if even if you remember like this, you will remember all the things. So general investigation to confirm like this, and then investigation to underline to find the underlying cause behind this presentation, and the last thing the investigation for the complication.
Yeah. Any approach you can remember, do it. But don't be stuck to the general investigation. They don't like to say general investigation only because it's wasting time for them. They want to hear something confirm the diagnosis or specific to your differential diagnosis. As in our scenario today, antiphospholipid antibodies, I should do them in the top of my investigation. Yes, after doing the investigation as general workup, I should do this to confirm my diagnosis. So don't forget. For the first case, how can I differentiate without doing the systemic sclerosis antibodies, anti-centromere antibody, for example? So I cannot leave the investigation questions without mentioning those investigation. By the way, sometimes even they are not happy whenever they hear the general investigation. They are telling to you, please skip to the next. So they don't want to hear the general. But if you give him an explanation that the general investigation are important in this scenario, he will be happy. For example, for the patient is having chronic disease, whatever, systemic sclerosis, what you want to do in the CBC, what the importance of CBC. It's SLE, for example. Yeah, exactly. So if you tell him, yes, doctor, I want to do just CBC to confirm if there is anemia, could be related to anemia of chronic disease, he will not say no, you cannot do it. But in the other side, he will be happy that you are giving explanation for maybe something not necessarily to do, but it's explaining something can be associated or complicated to your scenario. Okay, so if you want to give something, add, but usually make sense from the topic you add. Okay. Okay. Anyone has another comment you want to add before ending the session? Thank you, Dr. Salma and Dr. Henry, and a
Thank you.
special thanks Dr. Mahdoub as well. Thank you everyone for the attendance. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much, Dr. Basim. جزاك الله
Thank you,
خير.
Dr. Salma. Thank you, Dr. Salma.